Stroke. Etiology. Up to 20% of all ischemic strokes are cardiogenic in cause. Cardiac causes can be divided into a direct source of embolus or a substrate for embolus formation. Direct sources of embolus include left ventricular apical thrombus after myocardial infarction, left atrial appendage thrombus in patients with atrial fibrillation, AF, prosthetic valve thrombus in a patient with inadequate anticoagulation, valve vegetations, aortic dissection, cardiac tumors, especially atrial myxoma. Cardiac substrates for embolus formation include patent foramen ovale, PFO, aortic arch atheroma, left ventricular noncompaction, dilated left atrium or dilated cardiomyopathy. Physical signs. Common AF in up to 25% of patients who have a cerebrovascular accident. Murmurs, particularly mitral. Uncommon pulmonary edema. Added heart sounds. Investigations. ECG. There is a significant chance that if there is underlying cardiac pathology resulting in thromboembolism, the ECG will be abnormal. NB. When examining an ECG for a cardiac cause of stroke, look for AF. Previous myocardial infarction. In 90% of cases it is anterior. Persistent ST elevation suggestive of left ventricular aneurysm. Left ventricular hypertrophy suggestive of hypertension or aortic stenosis. Chest radiograph. Look for abnormal cardiac shape and size, pulmonary edema, and wide mediastinum suggestive of enlarged aorta. Echocardiography. If any possible cardiac cause has been identified from the history, examination, or ECG and CXR, it is reasonable to examine the structure and function of the heart with echocardiography. Contrast aids in the diagnosis of left ventricular thrombus. Transesophageal echocardiography should be used to search for aortic arch atheroma, left atrial appendage thrombus and function, and the presence of a PFO. For the diagnosis of a PFO, the patient is asked to perform a Valsalva maneuver and agitated colloid is injected peripherally. On release of the Valsalva maneuver, immediate passage of bubbles from right atrium to left atrium suggests a PFO. Treatment. Correct the underlying abnormality and aim for restoration of sinus rhythm where possible. Percutaneous closure of a PFO is recommended in young patients with any of the following: stroke or transient ischemic attack, TIA, where no other cause can be found; recurrent embolic events despite medical treatment; cerebral embolic events in more than one carotid territory. Complication. The risk of hemorrhage into an ischemic stroke if anticoagulated usually outweighs the benefit of secondary prevention. Prevention. NB. Anticoagulation in AF and atrial flutter. Indications for warfarin. Target INR 2.0 3.0. Previous cardiovascular accident or TIA. Age greater than 65 years. Diabetes. Hypertension. Structural abnormality on echocardiography. For all other patients, consider aspirin 300 mg once daily.